So Dr. Willoughby and I are going to co-teach these courses here, and I'm going to go through a lot of the basic information on immunotherapy, and then we're each going to take turns presenting some of our interesting cases to kind of help solidify the information that we're providing. So the first thing I kind of want to talk about is allergy as a whole. You know, if you look at a lot of conventional and even natural treatments for atopic illness, so allergic rhinitis, asthma, eczema, most of the treatment really gets geared towards treating the symptom. It doesn't really get to the root cause of the problem. So one of the things that I hope that you'll walk away with is that immunotherapy is really a way that you can help modulate the immune system to induce really a permanent change in the immune system. And it's really one of the few therapies I've ever come across that has the capacity to do this. When you're looking at, things like antihistamines and other medicines to try and help suppress that immune reaction to the allergen, again, you're just really dealing with that superficial layer of the problem and not getting to the deeper core. So I'm a naturopathic physician by training, so our job is to really get to the root cause of the problem, and hopefully this will be a way that you can help figure that out for your patients. So when you're thinking about all the things that disrupt the immune system, you really have to take a very global approach to your patient if you're not already doing that. And in environmental medicine, we always talk about this concept of total load, right? It's everything in a patient's world that creates symptoms. So we have to look at all these different factors that are influencing a way that their immune system's reacting. Of course, diet and nutrition is really, I think, the cornerstone of good gut health. We know that the gut accounts for 80% of your immune function, so when the gut's not functioning well, the immune system's not going to function well. Of course, all the chemical and environmental factors, pesticides, herbicides, household cleaning agents that they're using in their home, looking at their job, do they work in an occupation? Are they a nail tech person? Do they work as a mechanic? It's really important to understand where their occupational exposures are coming from, because that adds to their load. Medications and supplements, if you have someone who's on polypharmacy, they're on 13, 14 different medications, that's going to influence their immune system. Looking at their detox pathways, we talked a little bit yesterday in the pre-conference, if you had the opportunity, about some of the genetic modifiers that affect our detox pathways. It's good to know if your patient's a slow detoxifier or a fast detoxifier. Stress, of course, and lifestyle habits. Do they drink too much? Do they smoke too much? Do they exercise? All of that has an impact on the immune system. Anything that they're born with, genetic dispositions, metabolic problems, other physiological issues, all of that, of course, impacts the immune system. And the last one on there is really persistent infection. In my practice, I see a lot of Lyme disease, and if you live pretty much anywhere in the world, you're probably seeing it too. But chronic strep, chronic yeast problems, chronic Lyme, all this has a way of undermining immune function. So we're going to start off talking about food allergy specifically. And food allergy by definition is really a type 1 hypersensitivity. This involves IgE. And of course, this happens within, minutes of ingesting a food, where you get hives, angioedema, or even anaphylaxis. However, the delayed reactions are virtually ignored by the conventional medical community. And I think most of us, these are the kind of things that we're seeing in our patients. If a person eats a peanut and their face blows up, it's pretty obvious they're allergic to peanut. But what if they eat a potato or tomato and 2 days later they get joint pain? These are the kind of things that, even when people keep a very detailed diet diary, it can be very difficult to distinguish what's actually triggering a reaction. So these are the kind of things you want to be mindful with your patients as you're going through their food history. So, we use the term food allergy pretty loosely in medicine, but if you're talking with a board certified allergist, they'll pitch a fit and tell you, no, it's not an allergy. So I think, we use the term food intolerance or food sensitivity to better describe these delayed reactions to food. In my world, I kind of think of food intolerance as really being more the enzyme issues, lactose intolerance, gluten intolerance, casein intolerance. These are enzyme problems where your gut just isn't making enough of the right enzymes to break down the food or the protein properly. If you look at the research on what causes these type of delayed reactions, There's some evidence it might be IgG, although Dr. Willoughby was telling me earlier that IgG2 has actually been implicated in anaphylactic reactions, so it's not all IgE. I think there's better evidence that a lot of these reactions are actually type 4 hypersensitivities. You know, when you do the TB test in your patients, come back 2 days later and have it looked at, that's a type 4 reaction. It's delayed. And I think that explains a lot of these type of reactions we're seeing in our patients that aren't truly anaphylactic food allergies. And the kind of symptoms you're going to see in patients with food reactions, it can be anywhere from runny nose to asthma to gastrointestinal problems, arthritis, ear infections, seizures. It's a pretty lengthy list. So in my world, when you see people that have these chronic persistent symptoms and you've kind of gone down the list of ruling out other possibilities, I think it's a good idea to start looking closer at what they're eating as a possible explanation of what might be triggering their symptoms. So as I mentioned, there's different types of food allergies. What they call a fixed food allergy is your run-of-the-mill, straight-up food allergy, IgE-mediated, and it's reproducible. Every time you eat the food, you get the same reaction. Every time you eat a peanut, your lips swell, or every time you eat a peach, your throat gets scratchy. It's predictable, and it's the same kind of reaction that happens every time. Cyclic food allergies are a little bit different because they vary. They vary depending on how much was ingested. They vary on the time of year. They vary on a lot of other, things in the world. So I think of like oral allergy syndrome as probably being a good example that maybe you can only eat apples in the fall, but you can't eat it in the spring when birch tree pollen's out because birch pollen and apples cross-react. So it's that kind of thing. One of the things that you'll see clinically in your patients with food sensitivities, I work with a lot of kids, so maybe it's a little more obvious in children, but there tends to be this polar reaction to the food. Either they love it and they crave it, or they hate it and they can't stand it. So when you hear that in the history, sometimes it gives you a little bit of clue about what kind of foods are bothering them. Physically, and again, I see this a lot in children, probably more than adults, but I know for myself this happens. When you see the red ears, the red cheeks, the dilated pupils, you know that they've gotten into something that they're reacting to. And the vast majority of the time, it's food. I know for me, if I eat eggplant, my ears turn bright red. I look ridiculous. So no eggplant for me. Inhalant allergies is referring obviously to anything that you're breathing in. Of course, this can be pollen, tree, grass, weed, dust and dust mite, animal danders, chemicals, pesticides, anything that's coming in through your respiratory tract, through your eyeballs, all of that kind of stuff. And the reactions themselves, of course, as you can imagine, are going to affect your respiratory tract. So you're going to get the runny nose, the itchy eyes, the sinus infections, the bronchial infections, asthma, reactive airway disease, laryngitis, or oral allergy syndrome. But inhalant allergies don't just cause respiratory problems. You're going to see other types of physical manifestations with inhalant allergies. I'd say probably the biggest thing I see in my practice is with mold and skin problems. When you get somebody with eczema that's being really stubborn, food, the majority of the time, tends to explain the problem, and if it's not food, often it's related to mold. So again, it can affect the skin, the gut, the joints, the nervous system, and again, it's the cumulative load of what all these allergens are doing to your immune system that ultimately provoke symptoms. So just to talk a little bit about the kind of testing that's out there, skin prick testing has been the gold standard of conventional allergy testing for ever. And basically you put a drop of the suspected allergen on the skin, take a lancet, poke it about 1 millimeter deep in the skin, and then you look to see if there's any kind of wheal and flare. You have to use a positive and negative control. So typically saline with 50% glycerin is the negative control, histamine's your positive control. And then after you do the prick, you read it after 20 minutes looking for wheal and flare. Some allergists will actually look for delayed reactions, so they'll read it either 6 or 24 hours after they do the prick. Any wheal larger than 3 millimeters or flare larger than 2 millimeters indicates a positive response. And a lot of allergists like this, of course, because you can do a lot of antigens at one time, and some of the new test kits out there do multiple pricks at once. I think you can do 8 or 10 at one shot, so it's actually very efficient for allergy testing. Advantage of skin prick testing, it's actually more sensitive than RAS testing. Of course, you get the results very quickly, within 20 minutes. It's visual, it's objective, it's reproducible. And of course, you can test for all of the common allergens out there like dust, mold, and pollen. And it actually has a fairly low risk of anaphylaxis. The disadvantage is, if you've never had it done, is it doesn't feel very good. It does sting a little bit, and depending on who you're testing, a lot of people are very needle phobic and get very anxious about having it done. Although the risk of anaphylaxis is low, it's not zero, and it can and does happen, although it is quite rare. You can get false positives, particularly people that have very high IgE levels. So if someone systemically is running an IgE probably over 1,000, you're going to see a lot of cross-reactivity and false positives with RAS testing. Of course, with skin prick testing, there is a limit to how many antigens you can test at one time. So if you had a patient that had a lot of allergies and you wanted to test a lot of things, it would mean bringing them back multiple times often to do the battery of tests that you want to do. The size of the skin reaction doesn't necessarily correlate with the severity of allergy. This has been my bone of contention with allergists for years, is that it's very easy to want to correlate the size of wheal and flare, or even the size of a RAS number of class 6 must mean it's a terrible allergy. Sometimes it is and sometimes it isn't. So be aware of that when you're looking at these test results, that it doesn't always correlate clinically. Skin prick testing, of course, is contraindicated in people that obviously have skin problems, dramatic graphism, those type of things. Some kids with really bad eczema just don't have enough space to do reliable skin prick testing. And this is also contraindicated for people who can't stop their antihistamines or other, if they're on steroids or beta blockers. And they don't do this generally in children under the age of 2. So if you work with children and you've got an allergic child and they're less than 2, you've got to find other methods that are better suited. Skin endpoint titration, or SET testing. This is also called intracutaneous or intradermal testing. The concept is exactly the same as doing a skin prick. The difference is you're actually doing an intradermal injection of the antigen into the skin. So again, it's really done the same way. You're still doing a positive-negative control, reading it 20 minutes after you do the injection. One of the advantages of this, again, it's more sensitive to RAS testing. You get the results quickly. Still reproducible. You can do a little bit more with this than you can with skin prick testing. So if you want to test people for different drugs, particularly like penicillin allergy, bee venom, or stinging insects, you'll want to do SCT over skin prick. And again, it's more reliable for people that have this chronically elevated IgE. The disadvantages, the skin prick testing hurts. This hurts more, I think. There is a slightly higher risk of anaphylaxis during this, so after you do the testing, you want to keep people in your office for at least 20 minutes to observe them to make sure they don't have any kind of delayed hypersensitivity. And again, it's contraindicated in people that have severe food allergies. You would never want to do this on someone who has a known food allergy. And we don't do this, again, under kids under the age of 5. What this organization has been teaching for as long as I've been a member, and what I really love about this therapy, provocation neutralization testing, it's done a lot like SCT. The difference is we're not just looking at wheal and flare. What we're looking at is the patient's subjective experience as they're getting tested with each varying dilution. So what's really great and powerful about this is that, when people get injected with wheat and they start getting a headache, and then you start going down your dilutions and you're able to turn that reaction off, it just validates for them, oh, all these headaches I've been having for all these years is due to wheat. So the whole concept of this is that you're actually trying to provoke the symptom by giving them a stronger dilution. And as you work your way up through higher dilutions, which means they're weaker, and you find that neutralizing dose and it shuts the symptom off, it's really remarkable for both you and for the patient to see that, wow, this is really what this has been doing to me all these years, that was really able to kind of pinpoint. So it's really a very powerful thing for patients to have this experience. And especially if they've been through a litany of doctors that have been told, oh, you don't have any food reactions, you're fine, it's all in your head. Well, this just shows and proves for them, when you make the symptom worse and then turn it off, this is what's causing their problem. And if you've never had an opportunity, Dr. Doris Rapp has a set of videos that I'm pretty sure are out there on YouTube, or I think you can get it through her website, where she videotaped, I think, every kid that came in her practice for 20 years, where she would provoke them with whatever allergen she thought was the problem, and you would see changes in their mood, behavior, handwriting. She would have them draw pictures, and first they draw a nice sunny picture, and then they would inject them with candida, and they would draw something very black and dark, and then when she neutralized them, they were back to the happy picture. So again, I think it's very useful to see how much people change when they go through this kind of treatment. So the advantages of this, again, is that you get the experience of seeing what makes you worse and also what makes you better. And now your neutralizing dilution, when you're talking about treatment, is very specific. You know exactly what dilution you need to turn that patient's symptom off. In conventional allergy therapy, if you know you're allergic to dust or mold, they're just going to start you at a very weak dilution and slowly titrate you up over the course of usually 6 months. Where here you can cut to the chase, you can go right to the dilution that's going to turn that symptom off and start building immune tolerance. So you get results very quickly. You can find that neutralizing dose generally very quickly as well. And again, this is a reproducible type of testing and treatment. And again, you can test for really any number of different allergens. I mean, we're kind of talking it under the umbrella of food, but you can also do this with other type of allergens if you wish. The disadvantages really is just that it's a bit labor intensive. The reason is that usually there's 10 minutes between doing each injection. So once you start provoking someone, every 10 minutes you're giving them the next dilution, and it may take 3, 4, 5 dilutions from your provocation dose before it turns them off. So I mean, it could take up to an hour to do one allergen. So it's not uncommon that people spend 2 or 3 days in your office going through all the testing, trying to find out all their different allergens. But again, I think the benefit of it is so far outweighs the time you invest in doing it. The other disadvantage is because you're getting a subjective experience of the patient. Honestly, some patients just don't give you a very good subjective experience, and you're asking how they're feeling every time you give them an injection, and sometimes you get this wishy-washy. Well, I don't really know, and so if you're using that as a gauge to find your right neutralizing dose, again, sometimes that can be a little bit off. And again, you can't do this for people that have a history of anaphylactic reaction. Skin patch testing is used mostly by dermatologists for evaluating for contact dermatitis allergens, things like nickel allergy and so forth. However, there's actually quite a bit of research out there on using it for other allergens. And I think it's a very highly underutilized testing method. And of course, it's very easy, it's very safe, because you're really just applying the antigen to basically it's a piece of metal that's attached to a patch. You push it up against the skin, you leave it on for 2 days, and then you pull them off and you look to see if there's any kind of skin reaction. So again, this is something that anyone can do in any office. You can use it for adults, you can use it for children. It's very simple and easy. And again, you're just looking to see if there's any kind of reaction. So it's not measuring wheal and flare like more conventional allergy treatment, but if you're just trying to determine, are you allergic, this is very useful. So again, the advantages is it's non-invasive, it's very simple, and you can actually test up to 60 allergens at a time. So you can really cherry pick the things you think are bothering your patient, put them on the patches, stick them on the patient, have them come back in a couple of days and read it, and that's pretty easy. Of course, the disadvantages, of course, is that you got to keep a patch on you for 2 days, which means you can't get them wet. So a lot of people don't like the idea that they can't really shower while they've got their skin patches on. And if you treat children, children hate them and they want to rip them off. So you've got to find the right person that will be compliant enough to leave the patches on so that you get a reliable reading. A lot of people also get allergic reactions to the tape. The company I use, they've changed their tape at least 3 times, telling me every time, more hypoallergenic. I'm like, well, it was hypoallergenic last time, and people still reacted. But it's the nature that you're going to have some people who are really sensitive, and any kind of adhesive is going to bother them. So it's kind of the nature of the beast. But again, I think because it's such an easy method to use, it's worth utilizing with your patients. Results can be a little misleading, particularly if they have any kind of exposure to sunlight, if someone uses a lot of personal care products, lotions, and things of that nature, especially on the area that you're applying the patch. So I always tell people if they're going to have patch testing done, the day they come in, other than just regular soap and water in the shower, no personal care products, so we don't have to worry about that. So I'll talk a little bit about conventional immunotherapy, subcutaneous immunotherapy. Now we're getting more into the treatment aspect. This is conventional allergy shots. This is what every allergist has been doing for, 100 years. And it's been the gold standard for as long. The goal, of course, is that we're trying to build immune tolerance and desensitize the immune system to whatever it is it's reacting to. So when you're getting conventional allergy shots, generally you're going in, you start off once or twice a week, and then as time goes on, you're down to once a week, and then it's once every 3 weeks, once a month. And so it can take 4 to 6 months, again, to kind of get to your maintenance dose. And then once you get to the maintenance dose, then you're usually on once a month injections for anywhere from, 4 to 9 years. I gave you a list of this chart. I won't go through this. This is just for your notes, so if you're ever interested to see, this just kind of shows how you do the buildup. And then you start typically with a 1 to 1,000 dilution of the extract. You give, 0.1 of that, and if they tolerate that, the next time you give them 0.2 of the 1 to 1,000, and as time goes on, you keep giving them stronger and stronger dilutions until you hit the maintenance dose. So the dosing regimen's really standard. Pretty much every allergist in the country does it the same way. You can modify it, obviously, depending on how the person reacts. So if someone gets dilution number, they're on their 10th their 10th injection, and they start to complain that they're getting a little itchy or having problems, then you can modify it to maybe not increase their dose the next time, or hold them at that dose for a little bit longer. So there is a little bit of flexibility, but again, this is pretty standard in the conventional allergy world. And again, it can take up to 9 years to completely desensitize people. So whenever you're doing really any kind of immunotherapy with patients, they need to understand this is a long-term therapy. Although clinically you can see improvement sometimes within weeks of them starting immunotherapy, to get to the point where they don't need the injections anymore, and we'll talk a little bit about other types of immunotherapy in a minute, they just need to know that they're in for several years of treatment. But this isn't a very good option for people that hate needles, because it's a lot of needles quite often. Other types of immunotherapy, again, provocation neutralization is a testing method, but it's also a way that we can help determine what dilution is going to best neutralize the immune system. So again, I've got kind of the nitty-gritty details that I won't go through. You can read it on your own, that talks about how to do it. But my feeling is, if you're going to start doing this, particularly with foods, pick the top foods that are common allergens and start with that. And then if a patient describes in their history that there's certain foods that they're suspicious bother them, then add that to the list. But if you test everybody for yeast, milk, soy, corn, wheat, and egg, you're going to catch a lot of food reactions because they are very common. And for inhalants, you really need to understand where you live and where your patients live, because especially with pollen, there's quite a bit of variation depending on where you are in the world, the tree pollen, grass pollen, weed pollen, and so forth. So once the neutralizing dose is determined, they can give themselves injections once a day to twice a week, depending on the clinical need. So again, there's a lot of room, depending on your patient and how they respond, to adjust that dose. Anytime you give an injection, of course, at least the first time you give it, make sure they stay in your office to monitor them, to make sure they don't have any kind of adverse reaction. But generally, these injections, patients are taught how to inject themselves at home. Alternatively, you can use the neutralizing dose sublingually. You can administer it under the tongue instead of them injecting it, although the dosing frequency usually increases when you give it sublingually. So instead of doing it once or twice a week, generally, like when I do sublingual, it's done on a daily basis. So sublingual immunotherapy is, the concept is exactly the same as doing an injection. The only difference is you're administering the antigen under the tongue. And the goal is still the same, to desensitize the immune system. So the way that sublingual immunotherapy works is, these dendritic cells that are part of our immune system, so they're found in the buccal mucosa, they're found in the skin, they're found all throughout the body. These are really the tissue macrophages that are taking that antigen, showing it to the immune system to start building the immune tolerance. So what's basically happening is these dendritic cells start eliciting interferon gamma and interleukin 10, which actually have a suppressive effect on the CD4 cells. So ultimately what they're basically doing is suppressing these pro-inflammatory cytokines that ultimately trigger allergy. They also have this secondary effect on toll-like receptors. Toll-like receptors are also these immune modulating molecules and mostly found in our lymphoid tissue that help, dictate how the immune system reacts to these different allergens. There was one small study done here on children with dust mite allergy, gave them a dust mite allergen for 12 months, and they were measuring different cytokine and CD markers. And what they found is that there was an increase in IL-10, which is an anti-inflammatory cytokine, reduction of IL-12, which is a pro-inflammatory cytokine, and also reduction of CD86, which is necessary for T cells to proliferate, and it produces IL-2, and IL-2 is another pro-inflammatory cytokine. So basically, the sublingual mucosa has this limited number of pro-inflammatory cells, such as mast cells. There's not a lot of them in the mouth. So administering these antigens sublingually is very safe. In fact, I've gone through the literature trying to find the number of cases of anaphylaxis to slit therapy. There's 3. I found 3 cases, and all 3 cases were overdoses of pollen extract. And they were overdoses, and I mean, not like a little, like a lot. So the patients that had these reactions, instead of taking 1 drop, took like 100 drops. I mean, it was like that big of a difference. So far, the only 3 cases have been an overdose to pollen antigens. So again, very, very safe for your patients. I've got a bunch of slides here on the research. Again, because we've got so many slides to get through, I'll let you read these on your own. I just want to kind of summarize them that there's over 800 studies on slit therapy. It's been widely used around the world, mostly in Europe, for over 40 years. So this is nothing new. It's a little bit new to the US just because allergists get paid to inject you. But slit therapy, again, has been shown to be very, very effective. And I think one of the bones of contention with the conventional allergist is that when you look at the research on slit therapy, there literally is a 30,000-fold difference between the lowest antigen and the highest antigen on what works. And so allergists look and they go, well, we have no idea what to give people. But what's interesting to me is that it all works. So it kind of didn't matter. So keep that in mind if you're reading through these articles, that you'll see these wide variances on how it's delivered. But the bottom line is that it does work in almost all these cases. In fact, they've even shown in some of the comparative studies with allergy shots, it actually worked better. And they've done studies, most of the studies you'll find are done on pollen, there's some on mold, there's a lot on house dust mite. There's actually very, very few studies on food allergies, legitimate anaphylactic food allergies. There's a handful, they're very small, so I would be very cautious about doing slit therapy in somebody who has an anaphylactic reaction. I don't do it in my office. I think the risk is a little too high, but I'm also not equipped to handle anaphylactic reactions. So that's something if you're equipped to handle and you want to try, it's probably a very safe therapy, but just be aware that there is not a lot of research on doing this for conventional anaphylactic reactions. So slit's been shown to be very effective. Compliance is actually much better than it is with allergy shots. A lot of people, once they get a few years in allergy shots, they just get tired of it. They're tired of going to the doctor, tired of getting the shots. So they found in at least this one meta-analysis that 84% of people stuck with the slit therapy, where only 61% stuck with the allergy shots. They also found it's a lot cheaper. I mean, like a lot cheaper. So this was a study out of France, and a year of allergy shots was almost $4,000, where doing slit therapy for a year was less than $1,000. So quite a bit cheaper. So you can treat foods, molds, yeast, pollens, dust, animal danders, chemicals, hormones, neurotransmitters, and we'll talk about some of these other types of allergens in our next 2 segments. So slit can be effective up to 90% of the time. Again, this is based on the quality of the antigen, dose, and the duration of treatment. Again, I exclusively use slit in my practice. I don't do any injections at all. But again, I find it works really, really well. And again, clinically, I expect to see improvement in most patients once they get into their first 4 to 6 weeks of treatment. But it takes much longer to get them completely over the hump. So the advantages of slit, again, is it's non-invasive. The drops are administered under the tongue. So you as the clinician can really fine-tune what each patient needs to neutralize their immune system. So I like this, that it really is very individualized medicine. There is no one-size-fits-all here. We might have a starting place, but we really can adapt it to fit the needs of the patient. Again, it has an excellent safety record. People don't have to come to your office every week. They can administer this at home, so you get really tight control over the dose. And again, my experience is that I think it's more effective than conventional allergy shots. The downside to it, though, of course, is that insurance companies don't pay for it. Even though it has a great safety record and all this research, there still is no CPT code for sublingual immunotherapy. Again, there are some varying dosing regimens, so it takes a little bit of time and experience to figure out how to find that right dose for your patient. It does require the patient sometimes do multiple doses a day, so it is a little bit labor intensive for the patient. And of course, conventional allergists generally don't advocate for slit therapy. I've got some slides here on the actual how do you do it. Again, I just wanted this in your notes in case you're interested, and certainly anytime if you want to grab me outside of this to learn more about how you actually do it, I'm happy to talk that with you, but I just wanted you to have this in your slide set. And I did give you a list of some of the allergy companies that I use most common. Just be aware that the days of having allergy extracts that were free of phenol have kind of gone by the wayside, and Dr. Willoughby told me there's still one lab that is making phenol-free extracts. But it's important whenever you're doing allergy testing that you always test people for phenol because it's in all the extracts. And if they're phenol sensitive, potentially they're going to react to all the extracts. But here's at least a list of some of the labs that we use and get our extracts from. So I'm going to turn over to Dr. Willoughby to present. He's got a very long but interesting case. So let me fast forward to his. Okay. Yes, I'll let Dr. Willoughby take over for that.
Can you hear me? I talk softly, so you have to let me know if you can't hear me. The laboratory that you can still buy phenol-free extracts from has been recently sold. ALK bought Allergy Labs of Oklahoma, but they still have a stock of phenol-free allergenic extracts. So we're going to lose our abilities to get some good tools soon. And I'm kind of with Darin. The majority of my children, I'm a recovering internal medicine pediatric doctor, but I also got tainted by this about 1959 when my dad started doing this with Herb Rinkle. And I will guarantee you this is much kinder treatment than you're going to get with the conventional therapies. First case is very long. I'm going to try to abbreviate this. And actually, I thought it was going to be a 50-minute presentation. If I can back up one, I'll do good. Uh-oh, I blew it. Because I don't know where we are. Right here? I hope. Or this one. Let's just do it. Sorry. Not used to this. That's fine. Anyway, I'll just start this. You have the slide. This was a 48-year-old white female patient who was referred to me by her allergist from Chicago. She had a long history of asthma, eczema, a variety of other things, but she had an interesting history that she actually was a overseas airline stewardess as well as an OR nurse. And he had previously used neutralization therapy with aeroallergens, food additives. He'd given her bioidentical progesterone for her hormonal needs, nutrient supplements. She'd also used food elimination rotation, which relieved her rhinitis, asthma, fatigue, and perimenopausal symptoms. In '97, she moved to Kansas City, remaining drug and symptom-free, working as a nurse with only seasonal exacerbation of her inhalant allergies and yeast infections, which always followed antibiotic treatment. So that's one of her chronic issues that Darin had mentioned. Oh, I did it again. But I'm just going to use the computer. Forget this. I got it. We're there. I'll get there. I'm just using that. Okay, I'm sorry. She had come to me after she'd crashed. Wait a minute. And then she became ill. She had crashed after resuming flying part-time. She'd actually had a house in Amsterdam, or London, excuse me, at that time, as well as Kansas City. And she was flying between Kansas City International and Amsterdam, developed a cold in 11 of 4. And the anaphylactic episodes began following meals consumed late in flights. And then after that, her allergies dramatically worsened and spread to other organ systems. Medical treatment failed, and she worsened to the point she couldn't complete a day of work. She became increasingly sensitive to fragrances and odors and developed all over itching, generalized swelling, especially of the eyes, face, lips, and throat, severe fatigue, chronic vaginitis, and increased menopausal symptoms. Multiple ER visits requiring nebulized albuterol, IV steroids, and oral prednisone tapers occurred. She had seen an allergist in Kansas City who instituted the usual maximum medical treatment without much benefit. We kind of reviewed her history. In infancy, she had a history of colic, which might indicate to you maybe she had some food intolerance, or her mother did. This was especially clear when she said that she was intolerant of breast milk, as well as all formulas, especially cows. Early childhood, she developed hay fever, asthma, conjunctivitis, began having sinus infections by the time she was about 6 or 7, and recurrent ear infections. During her teen issues, she had developed some emotional issues, especially PMS during the menstrual cycles, and with trying birth control pills to remedy this problem, she became very ill. She also had antibiotic treatment for acne, and this, as well as steroids, would cause vaginal yeast infections. She got rashes from earrings, and she started developing hives after eating. As an adult, the menstrual cycle symptoms, including headache, fibrocystic breast disease, and other menopausal symptoms, increased. She began having anaphylaxis with crab, shrimp, and mushrooms. Seasonal allergies increased in severity, and as did the foods, which caused fatigue, cold intolerance, brain fog, and occasional memory lapses after eating. Just couldn't get well, and treated by an environmental allergist, and thank God she found him in Chicago. She also had some drug allergies, erythromycin, ampicillin, and avacristine, combined with pseudoephedrine, caused itching, hives, and yeast infections after the antibiotics. She also began reacting to other prescribed medications in a similar fashion. I'm not going to list them all, there are several. Food allergies, obviously, the shrimp and crab anaphylaxis, but then she discovered when she worked with the other allergists that soybean caused itching and hives, dairy products created GI issues, and enzymes did not help with that. She also developed breast swelling with dairy products. Coffee caused itching. Tomato, peanut, wheat, chocolate, orange, and mushroom were other allergens that were found to create these symptoms. And when she came to me, this was just the medications. You can read that later. We know she had environmental allergens to all the inhalants, as well as food additives. She had a history of worsening in the spring and the fall, even with her food allergies, and especially with weather fronts, musty places, and dust. She'd become intolerant of fragrances from flowers, perfumes, and various fumes at the workplace, especially when she was around copiers or laser printers. And basically, this goes through a long list of symptoms. We don't need to go through that. The physical, I don't think we need to. You can read that. She also had a chemical intolerance, which created headache, fatigue, eye symptoms, redness, burning, itching, brain fog, and fatigue. And so what we did with her is we did sublingual, which I prefer for any chemical. I don't like injecting chemicals. And at least this was the plan, to do these for phenylglycerin, as she had a good history consistent with that. There are lists you can get that'll indicate what chemicals you might be exposed to. And obviously with the fragrances, perfume, and the old carrier that was in all the good old Avon products like Orris Root. And then we had her avoid things, and we gave her some dextromethorphan, 15 milligrams, one by mouth every 8 hours. That was done because it will affect the nitric oxide system. It blocks the NMDA receptor. And then we talked about sublingual neutralization. And we did evaluate her inhalants by serial endpoint titration because she opted to do a treatment with injection immunotherapy, IC, intracutaneous injections. And with that, we started on endpoints, and she was built up to a full dose in about 10 weeks' time, so she got fairly rapid relief. The food allergies, back up. We again had a huge history of that, and we're going to evaluate for milk, wheat, and a variety of other foods, but you're going to find out you can't do them all in one day quickly. So we just had her eliminate wheat, milk, soy, yeast, corn, tomato, and sugar for 6 weeks and put her on a low carbohydrate or low amylose diet to help with inflammation. We also had her try trisalts, 1/2 to 1 teaspoon, in about 4 to 6 ounces of water. It alkalinizes, physiologic processes because you need an acidic environment to release mediators. So that's helpful to a lot of these people, especially with foods and chemicals. I give her a female hormone questionnaire to further evaluate her female hormone systems. We had her do basal body temperatures because of the fatigue, chilling, and some other features that made me think it might be thyroid. We did thyroid and female hormone panels. We gave her some difluconazole, I shouldn't have said that, for her vaginal candidiasis. And she also, I think, had systemic. She opted not to pay for a stool test. When she came in to get tested for chemicals, this is our first testing day. She had some symptoms of wheezing, coughing, and postnasal drip that she rated at 3 out of 10 for each of those. We began with phenol because you're going to blow somebody up if you try to test a chemically sensitive patient for your inhalants, and it has phenol in it many times. So we started on the number 1 dilution. We can use varying dilutions with this. I learned from some of the older guys, and I used 1/10 of a cc sublingual of the phenol at 8 minutes. She developed itching between the shoulder blades, increased to a 7, increased cough, runny nose, postnasal drip, and developed a tinny taste in her mouth, which you'll see with some of these chemical patients. At number 2, she had increase in runny nose at 8 minutes, became lightheaded, her eyes itched. At 15 minutes, everything improved. So many times what you'll see is we talk about, observing for about 10 minutes, but I learned many years ago that if you watch them for an extra 5 or 10 minutes, sometimes you'll find these symptoms tend to change in that period of time if you're not sure of quite where you're at, especially when you're using sublingual. And then the number 3 phenol, we again induced symptoms, and then those had all resolved and went back to pre-test. So we had a relieving dose of 1/10 of cc of the number 3. With glycerin, we used number 1 dilution, 1/10 of cc, 3 minutes. She developed generalized itching. This is something you will see. These things, you'll be surprised. Sometimes people may react within 30 seconds to 10 minutes. You just don't know. And that was the only symptom we got with that. The number 2, at 3 minutes, she had increased cough and wheezing to a 7, and itching decreased. Number 3 dilution at 5 minutes, increased cough, wheezing, chest tightness, but her itching resolved. Then we went to number 4, 1/10 of a cc at 8 minutes. She had developed itching of the tongue, and at 10 minutes, cough, wheezing, and chest tightness had all returned to better than pre-test because they'd all been 3 ahead of that. And then we went on to our SET because I always test chemicals before I do any testing for your inhalant allergens with a patient like this. And with a patient experiencing severe asthma, angioedema, urticaria, and anaphylaxis, you got to be kind of cautious. So I use more dilute. What we typically will do is use what we call, in the good old days, they call them screening. I know that's not good for you with insurance these days, but we start at the 6th dilution, which is 5 to the minus 6th, which is way out there at about 1 to 312,000. And so we introduced a panel of those. What I generally do will look for like your major fall pollen, like ragweed. I use a ragweed mix. We used a mixture of grasses for grass season, and a tree mixture to indicate what trees may do. We also did Dermatophycoides farinae and Ternicinus, the 2 dust mites, dust, alternaria, and cladosporium. And then I generally will do a positive, just like Darin. You got to have a histamine positive control. I use a 50% glycerin like he does to look for an irritant control with your skin testing, because you're going to have the same diluent in there. I usually start about a 10% dilution for that. And then I also use a screen with just regular phenylated saline, because I have seen many people react to this as well. 10 minutes after we applied the intradermal tests, and this is after we'd given her that relieving dose for chemicals. These were all negative. The histamine was a 9 millimeter wheel, glycerin was a 7 millimeter wheel, and phenylated normal saline 5 millimeters, with application of a 25-fold more potent dilution than number 4. Patient reacted at 8 minutes with kind of a deer in the headlights kind of look on her face. And I went, oh boy, here we go. She developed anxiety, overwhelming fatigue, nausea, and headache. We discontinued testing. We gave her another dose of her chemical relieving doses with the phenol and glycerin, gave her some trisalts, and she improved about 25%. With the second round of trisalts, another 10%. And then we kind of looked at these, and her ragweed had increased to a 12 millimeter wheel, 9 millimeters with grass, and 7 millimeter with trees. The remaining antigens were negative, so she was really sensitive to her pollens, which is not unusual. So we decided we better cease and desist for the day. You'll run into this once in a while. This is a very sensitive, unusual patient. She resumed testing, reported feeling tired and flu-like until the Sunday after testing, which you may see. She awoke feeling good. She had eliminated known food allergens, which she had not been doing, initiated her low amylose diet, and used trisalts to relieve symptoms as they occurred in the interim. And she'd taken her fluconazole daily, and got on a probiotic, which we recommended. And she came back wanting to get tested for more, so she was, brave, I would say, after that. This day, we'd done a little more conversation about chemicals, and she had, we decided that we would test for things like formaldehyde, which I know is an interesting allergen and it's ubiquitous, but we started that. She developed immediate chest tightness and cough. And I never start formaldehyde at a number 1 dilution. It's just too potent. We always start with a number 2. These are the things you want to try as you've gotten used to this and get a little bit more experience. Excuse me. With the number 3, the chest pressure decreased to 1, postnasal drip increased to 8, and the cough had resolved. At the number 4, the chest pressure, postnasal drip, cough, and itching all resolved, so that's a neutralizing dose. We were able to then test orris root. About 7 minutes, she developed severe chest tightness, throat closing, nasal congestion, clammy skin, faintness, and cough. We placed the number 2 dilution sublingually at 6 minutes. The cough remained the same, postnasal drip resumed, and chest pressure decreased. Number 3, the cough increased, the nasal The rhinitis increased, and she developed arm itching. Facial flushing was noted, and after about 10 minutes, we applied the number 4. At 6 minutes, all symptoms were resolving, and at 10 minutes, only a cough rated at 1 out of 10 remained. All the other symptoms were relieved. And we tried perfume at the number 1 dilution. She developed congestion, ear itching, and for the sake of kind of abbreviating this, because this is a long case, she developed a number of the symptoms she'd complained of, which each and every one of these, and then we were able to give her some neutralizing drops to cover those things. Her lab had come back. She had an average of 6 basal body temperatures of 97.1 degrees Fahrenheit, which in the good old days would have kind of indicated you might need some thyroid. She had a normal TSH, normal free T4, a low normal free T3, but she had a very low total T3, reverse T3 ratio, which meant she needed to get a little bit more free T3 in the mix. At that time, we went ahead and added a half grain of USP thyroid, porcine thyroid, 1 twice a day. And later I found out that this lady had thought I said kosher. She was like really freaked out because she was a nice Jewish lady. But we had a long discussion, and she decided that she felt so much better with this that she would take it anyway, since it was a drug. We started also on vitamin D. Her 25 hydroxy D3 had been 27.8. I started on 10,000 international units, 5 a day for about 15 days, then 1 a day to get that up and running to around 100s where I like to keep it. And then, of course, the menopausal labs, you can read those. For the chemical intolerance, we did give her sublingual drops compounded from phenylglycerin, formaldehyde, orchid perfume. Trial dose was administered in the office just to be careful. She did well with that, and then she was to use 3 drops, which is 1/10 of a cc, prior to expected contacts or after exposures as needed. And she could repeat that at 20 minutes. I don't know what my time is. And she was to continue trisalts as directed, since those had worked really well for her food and chemical reactions when she was away. We continued the dextromethorphan, and then we were able to complete skin testing. This will give you an idea of how sensitive she was. She was quite sensitive to certain things like the pollens, but we'd also found out she had parrots, cockatiels, all kinds of animals at home, and she was sensitive to those, as well as things like grain smuts, grass smuts. And she opted to start with sublingual immunotherapy because she just didn't really like shots, and she had trouble carrying the injections on international flights. And I do this a little differently than Daryl. I just use the standard way we do this. And I was taught many years ago when I started doing sublingual to use weekly doses, and this works great. Because, and when you talk weekly, there's no set rule. The reason that we do weekly allergy shots is the first allergy clinic in the United States was Johns Hopkins, and they were open on Wednesday afternoons. The patient needs a repeat dose whenever they redevelop symptoms after they're getting relief. And maybe the first few weeks you'll want to apply them a couple times, or you can go to daily doses. But I learned how to do it with weekly, or once a week, or every 4 days, 5 days, and that's the way I continue to do it. I learned this from a gentleman named Frank Wakeman many years ago. And then we went on to do some more testing for her foods, because she was really interested in getting those done, and chemical drops had helped her so much. And by then, just with the medical management and a little bit of avoidance, she had been able to return to work with only a minor increase in symptoms after 2 to 3 hours. She was still crazy enough to work in an OR where you're totally contaminated with chemicals, and she had been on her hormone replacement, those symptoms increased about 50%. Fatigue was 60% better. Vaginitis had resolved. And by following an elimination rotation diet, she discovered she also had a corn and yeast sensitivity, and had really learned how to rotate well. But she still complained she couldn't eat out or snack at work without getting symptoms. So it's the way it works. And her inhalant symptoms were about 50% better because it took only about 6 weeks to escalate her dose to a maintenance dose with the sublingual, because I'm very aggressive with that, because I think that, if you start at the end point, or the fourth dilution, fifth dilution in this case, then you just rapidly escalate them through that to the strongest tolerated dose. And she was just to continue other things. She opted, she wanted to be able to adjust her hormones, so I had her get a book by a gentleman named Uzi Rice called Natural Hormone Balance for Women. He was probably one of the first guys in the country, next to Jonathan Lee, that began doing hormone replacement. But his book's still a good guide for ladies to adjust their hormones. So, we went into food testing, and please tell me when I need to cut off. We'll just cut me. Okay, I'll tell you what, we're going to cut this here. This is a very lengthy history of it. Thanks. I guess we better go to a break and stay on schedule. And I forgot to tell you, I do not have any financial interest with any products related to medicine nor dentistry, and have not been given any monetary grants for speaking. Thanks.